Well, greetings, everyone, and welcome to the EKG Case of the Week for May 26, 2014. First of all, happy Memorial Day to everybody out there, and for all of those folks that are serving in the military overseas, we're thinking about you. This being a May 26th Memorial Day, hope everyone has had a good Memorial Day weekend. Second thing, this is not going to be a typical EKG or ECG Case of the Week, because this week what we're going to be doing, as promised, is reviewing the answers to the 2014 residency, University of Maryland Emergency Medicine Residency EKG competition, which was held April 30th, 2014. I've been sending tweets and some emails out to everybody out there just to let them know about this competition. And before we even get into it, before I get into the answers, I want to make sure everybody has an opportunity to make the most of this. And I've been letting everyone know that you can download a copy of the test questions. There's only 20 cases, 20 questions, and they are bread and butter emergency medicine cases. They're tough, but they're real emergency medicine cases. And if you haven't looked at the cases, please look at them before you go through the answers. If you just go right through the answers, you will definitely be shortchanging yourself of an opportunity to learn something and also test yourself on real cases. So you can download the PDF of the questions by going to lectures.umem.org/2014 ECG competition. Do not put www first. Just type this into your browser and you'll be able to download a copy of the PDF and go and take the test before you come back and take a look at the answers here. If you definitely don't want to do that, then as we go through the questions, hit the pause button before we talk about the answers for each question. All right? This is going to be a little bit longer than most of the podcast or video casts that we've done, but I'm going to try to move along quickly. If you have questions, send me an email. There's my email, which I put on the first slide of every single case. And for those people that are into, actually, that's my Twitter handle. There's my email right there. And people still don't send emails to my proper email, so use that email, the Comcast email, and you'll be able to get in touch with me much more quickly. All right? And this is the website where hopefully you are looking. Okay, let's get started. Oh, by the way, the content for this test is available on an EKG workshop that we've put together for eMedHome, www.emedhome.com. It's called a Premier ECG Workshop. So if you find these test questions challenging, check out the course content that's available on eMedHome, because it will take you to a level, hopefully, where you should be able to answer these questions without too much difficulty. All right, let's get started. Question number 1. Which of the following statements is true regarding Q waves? In the interest of time, I'm not going to read through every detail of all of these questions. We're just going to go right to the answer because, again, I'm assuming you've already looked at the questions. What is the answer here? Well, the answer here is answer B. What are significant Q waves? They have to be at least one little box wide. If the Q waves are more narrow than that, then they are not significant size Q waves. They also have to be about 1/3 to 1/4 of the size of the entire QRS complex, but the duration, they have to be at least one little box wide, 40 milliseconds. A lot of people mistakenly think about answer C as being correct, but actually this is incorrect. Q waves, we know, can develop within a couple of hours of onset of infarction. So answer is letter B. Question number 2. Which of the following statements is true regarding MI involving the right ventricle? And the answer here is D. Essentially, what we're doing is describing an inferior MI. ST elevation leads 2, 3, and AVF. And whenever you see ST elevation in V1 with ST depression in lead 2 simultaneously, you've just nailed the diagnosis of right ventricular extension of the infarction. So this patient has an inferior and right ventricular MI. What else can we say here? This is a bit of a trick question. Up to 5% of all posterior MIs are isolated posterior MIs. Isolated right ventricular MIs are enormously uncommon, if at all, that they occur. All right, so the answer here is D. All right, moving forward now, let's get into some EKGs. Question number 3, patient with a known history of left bundle branch block presents complaining of chest pressure. There is the EKG. What's the best treatment? Well, you have to be able to recognize that this patient with the left bundle has evidence of Scarbosa's criteria, which is notable in V3. There is concordant ST segment depression in V3, and that means that this patient needs to be treated as a STEMI equivalent. So the answer here is A, aspirin, heparin, and they get lytics. That's the best answer, all right, based on the literature out there. Now, there's also some significantly abnormal QRS and ST segment discordance in some of the lateral leads and maybe in lead 1 and lead AVL, and this is reflective of the revised Scarbosa criteria, which we've talked about before, and I'm not going to get into right now, but you know what, even if you don't know the revised criteria, standard Scarbosa criteria would say that purely based on lead V3, this patient has a STEMI equivalent, and that means that they get thrombolytics. Answer A. Next question. A patient demonstrates ST segment changes noted below during active chest pain, and that's a key word that I'm throwing in there. This person is active chest pain. What's the most likely significance of the findings? And if you've been following along or you've taken that curriculum on eMed Home, you know that these are de Winter T waves. Essentially, what you see is you see upsloping ST segment depression in the precordial leads, shooting up into what I've referred to before as rocket T waves. They go shoot straight up and straight down. They're symmetric and very tall. So upsloping ST segment depression, shooting up to very tall rocket-like T waves. Those are de Winter T waves. And de Winter T waves are significant, or they imply an acute left anterior descending artery occlusion, not subacute and not left main. All right. So this is an acute left anterior descending artery occlusion. This is not to be confused with Wellens waves, which are in the next question. Wellens waves are notable for a subacute LAD occlusion. So again, with de Winter T waves, you need to move quickly. These are acute LAD occlusions. With Wellens, these are subacute. So I'm not saying that you move slowly, but they don't need to go to the cath lab quite as quickly. With de Winter T waves, the literature seems to suggest that they ought to go to the cath lab very, very quickly, like right now. Whereas with Wellens, if they're not actively having pain, and the way I've described this question number 4, this patient's pain has now resolved. De Winter patients, their pain is still ongoing. Wellens patients, typically their pain has resolved, and so they just need to be admitted and treated in the cath lab during that hospitalization. So with Wellens waves that are in question 5, the answer is C. You want to admit them, and they ought to be treated for non-emergent or with non-emergent cath, not necessarily emergent cath. You wouldn't necessarily need to activate the cath lab at this moment because the patient's asymptomatic. You're not going to activate the cath lab for somebody who's got an asymptomatic presentation. All right. All right, moving forward. Question number 6. This was actually one of the EKG cases of the week that we did just several weeks ago. Patient comes in with 30 minutes of chest pressure. Her initial EKG during pain is shown. Previous EKG is completely normal. So you have to recognize what's different now. Well, what you see here, the previous EKG is completely normal. So what we now see is that there's flipped T waves in AVL. And there might be a suggestion of flipped T waves out there in lead 1 as well. So the main thing I wanted to focus on was the flipped T waves in lead AVL. And when you see new T wave inversions during pain, all right, new T wave inversions during pain in AVL, that is notable or should make you worry about early inferior wall STEMI. All right, so that's what diagnosis you need to suspect, early inferior wall STEMI. Now, some of our residents pointed out when we went through this in conference that this could also simply be lateral wall ischemia, and because their lead 1 and AVL are lateral leads, and if you have T-wave inversions in 1 and AVL, that could simply be lateral wall ischemia, and so I would take either answer B or answer D. What I wanted them to pick up was that new flip T-wave AVL, you worry about inferior STEMI, but it could simply be lateral wall ischemia as well. All right, so I'll actually take answer D or B with the residents. All right, number 7, 55-year-old man comes in with shortness of breath and lightheadedness, borderline blood pressure. What's the most immediate treatment? This patient has some strange type of AV block. I don't know if anything maps out, but strange and bizarre. And the word bizarre should make you think about hyperkalemia. The patient has big peak T waves, well, kind of sharp-looking T waves, and that should make you think about hyperkalemia. And we talked multiple times about how hyperkalemia can produce strange or bizarre Brady dysrhythmia is the answer here. What's the best immediate treatment? Your answer is calcium. All right, so transthoracic pacing we've talked about before. It doesn't work. Epinephrine, atropine, they don't work in the presence of hyperkalemia. And what you need to look beyond, the bradycardia and recognize the peak T waves. This is hyperkalemia, and the patient needs to get some calcium. All right, number 8. This is a 35-year-old man that presents with mid-sternal chest pain and shortness of breath. A lot of people mistakenly thought this was pericarditis. I guess probably because of the patient's age and, I don't know, maybe in one lead or one QRS complex, there's some downsloping PR. But we've talked again before that you cannot pay too much attention to PR segment depression. There's a couple things that we've talked about before that are highly notable for STEMI. We've talked about the check mark sign. QRS comes down and bang, shoots off into the T wave, and you clearly have that check mark sign in a handful of leads. Pericarditis just doesn't do that. And then looking out here in a couple of the leads from V4, you've got the R wave coming down and shooting right out there. So pericarditis doesn't do that. Pericarditis does not shoot straight out like that. Pericarditis doesn't give you the check mark sign. This was a fairly young person who, sure enough, had a full-blown STEMI. He went to the cath lab, and as I recall, he had a big wraparound LAD lesion and ended up needing to get stented. All right, but there was some delay on his initial evaluation because people thought that he had pericarditis, and the reason people thought he had pericarditis was because he was only 35. All right, he was relatively young. Number 9. 49-year-old woman comes in with severe chest pain and shortness of breath, and I think this is actually similar to a case that we reviewed in the EKG case of the week just 1 or 2 weeks ago. Patient has flipped T waves in the inferior and anteroseptal leads. You're done. This is a PE. Answer is B, heparin. All right. Next question, number 10. 36-year-old comes in after syncope. Now he's asymptomatic. So what kind of things do you look for on the 12 lead of an EKG after somebody has syncope? Well, one of the things that you've got to look for is noted here. You see high voltage, and you also see deep, narrow Q waves in AVL. These are not infarction Q waves. They're too narrow, right? Deep, narrow Q waves in those lateral leads. This is hypertrophic cardiomyopathy. What's the best initial diagnostic test? Answer, Doppler echo. Whenever you suspect hypertrophic cardiomyopathy, get a Doppler echo, okay? Number 11, this patient has a regular, really wide complex tachycardia. Again, if you're a regular watcher of the videos or you've been through that online course, you know regular, really wide QRS complexes. When the QRS complexes are bigger than 200 milliseconds, look how wide that is. First, second, and third thing you think about is not VTAC. You've got to think about metabolic or tox problems. So of your choices up here, which is going to be the best treatment? You go with calcium. This turned out to be severe hyperkalemia. Normal VTAC typically doesn't get this wide. When you see QRS complexes that are this wide, think tox, think metabolic. Most common metabolic problem, of course, is going to be hyperkalemia. Go with calcium early. We've talked about that a number of times. Again, I don't want to sound redundant by continually saying we've talked about this, we've talked about that, but we have. So just keep on reviewing this stuff. Keep up with the videos. Number 12, this is a little bit tougher, and I think a few people got this right amongst the residents, but this is definitely tougher. 45-year-old man comes in feeling nauseous, malaise, generalized aches. He has no chest pain, shortness of breath, or sweats. Blood pressure is a little bit low, but not awful. What's the best treatment? Well, when you go through this EKG, hopefully you have some type of method to your madness when you're going through an EKG. Rate, rhythm, axis, intervals, ischemia, hypertrophy, infarction, whatever method you go through, hopefully you always pay attention to the intervals, all right? And when you go through the intervals, the PR is, maybe the PR is just a little bit long, but fairly nonspecific. PR QRS is the other interval you ought to look at. The QRS is pretty normal. The QT you ought to look at as well. And hopefully what jumps out at you is the fact that the QT is actually very, very short. All right, it's not something we've talked about before too often, but we have, well, at least once or twice, short QT. There's only a couple of things that produces short QT. One of them is digitoxicity, which there's nothing here suggesting definite digitoxicity. There's no Salvador Dali mustache-looking T waves. The other thing that produces short QTs, which can give you nausea, malaise, generalized aches, constipation, a bit of a low blood pressure, and so on. This is hypercalcemia. And everybody who's hypercalcemic is dehydrated. Give them IV fluids. So your treatment of choice is IV fluids. A handful of residents did nail that one, but I thought that was a tougher one. All right. So short QT, think hypercalcemia. Number 13, 55-year-old man who recently had a STEMI, then got thrombolytics an hour ago, and now he's asymptomatic, but he suddenly develops this rhythm. It's regular, it's wide. The rate is about 110. What does that mean? It can't be VTAC. If you looked at this and called it VTAC, you're wrong. The rate is too slow. To call it VTAC, it's got to be at least 120 or 130. When you see something that looks like VTAC but is a bit slower, especially after getting thrombolytics, this is accelerated idioventricular rhythm. It's a reperfusion arrhythmia. What do? Nothing. You put your hands in your pockets and step away from the stretcher, and it usually resolves after just a few minutes. So answer there is D. This would kill the patient. That would kill the patient. That would just piss off the patient. All right, probably wouldn't kill him, but it would make him very angry. This is what you do. This is a classic boards question as well. All right, number 14. 40-year-old man comes in complaining of intermittent episodes of near syncope. This is another thing that you always try to look for in syncope and near syncope patients. This EKG is obtained during an episode of near syncope. All right, blood pressure is okay. What's the best medication? Well, it's irregularly irregular, so it's AFib. And the morphologies are changing. Some are more narrow, all right? Some are really wide, and there's variations in between. In some places, you're getting rates that are extremely rapid, near 250, almost close to 300 beats per minute, and that is diagnostic of atrial fibrillation with an accessory pathway, AFib with WPW. And your drug of choice there, if you're not going to shock them, drug of choice, procainamide. Magnesium won't help, probably won't hurt. Beta blockers will kill them. Amiodarone probably will decompensate the patient as well. Procainamide, drug of choice. All right, or just shock them, but that's not a choice. 15. 45-year-old woman presents complaining of 2-hour history of lightheadedness and palpitations. What is the rhythm here? Well, there's a right bundle, but you know what? Nobody asked you about that. We're asking about the rhythm. And so what is the rhythm? The rhythm is irregular. Okay, what kind of things give you irregular rhythms? AFib can, MAT can, A flutter with variable conduction can. So AFib should not have clearly distinct P waves, and if you focus just on the rhythm strip, there really are not clearly distinct P waves, but whenever you're looking for rhythms, you always need to look in all of the leads. And again, we've talked about this. The best lead to start your rhythm interpretation with is V1. V1 is your money lead when you're looking for P waves. And now when you look carefully at V1, you can appreciate that there are P waves and they are fluttering. The P wave rate is probably close to 300. This is atrial flutter. It's not AFib. All right, so there's your answer, atrial flutter. Always look in V1. That's your best lead to start your rhythm interpretation with. All right. Getting close to the end. Number 16, 50-year-old man presents after syncope. He's unstable, right? He's got a blood pressure of 80/40. So you need to figure out what the rhythm is and what you're going to do about this unstable bradycardia. So when you're trying to figure out what the rhythm is, the first question you have to ask yourself is, are there P waves? Yes, there are definitely P waves looking down there at the rhythm strip. So second thing is, we're going to map them out. Well, that's definitely a P wave. Well, if you use your calipers and keep mapping at that spacing, it maps into that T wave. In fact, that T wave looks a little bit larger than normal, so maybe there's a buried P wave in there. Well, you keep mapping, and it certainly does continue mapping. So this is regular P wave activity, all right? So now you need to look at what the PR interval is doing. And if you look at what the PR interval is doing, hopefully you'll appreciate that that PR has gotten bigger there, and then the P wave is not conducted. And then it starts over again. PR there has gotten bigger, and then the P wave's not conducted, and so on. So this is Mobitz 1. And what do you do for unstable Mobitz 1? You give them atropine. Atropine would be a perfectly reasonable thing to do. You could pace the patient, but that's not an option. There's no option that says Mobitz 1 with pacer. So Mobitz 1 with atropine is the best answer here. All right? Next question, number 17. 26-year-old comes in after syncope, now asymptomatic. What are the things you look for in patients that are post-syncope? Well, this is one of the ones that you always look for, especially young people. This patient has kind of a right bundle-ish type of pattern in V1 and V2, and there's also some ST segment elevation, which is very abnormal because normally right bundle patterns give you ST depression in V1 and V2. So here's a incomplete or kind of a incomplete-ish right bundle pattern with ST segment elevation after syncope. You've got to worry about Brugada. And what do you do for Brugada? You send them to an electrophysiologist for testing with a sodium channel blocker. That's what the electrophysiologist will do. They'll infuse a sodium channel blocker because Brugada syndrome is presumed to be a sodium channelopathy, and they'll give them a sodium channel blocker to really make things worse. And when they infuse the sodium channel blocker, one of two things will happen. Either the patient will develop worsening of the Brugada pattern, and if it does, that confirms the diagnosis. Or secondly, the other thing that can happen is the patient simply goes right into polymorphic VTAC, and that will also confirm the diagnosis. In either of those cases, the patient if they go into polymorphic VTAC, they just get shocked, and then in either of those two cases, they then get an AICD because the diagnosis is confirmed, and the patient happily goes home. All right, so you need to send this patient to an EP person, and what they do in the EP lab is they give them a sodium channel blocker. Okay, number 18, 29-year-old comes in with palpitations. Blood pressure is pretty good. What's the best immediate treatment? Now, a lot of people will mistakenly call this SVT because the patient's only 29, and that's a big mistake. Don't ever rule out VTAC just because a patient is young. This patient had VTAC. How do you know? Well, there's a couple of things. First of all, you've got this thing in V1 called steeple sign. QRS goes straight up and straight down. There's not even rabbit ears. When the QRS goes straight up and straight down, that is VTAC. What else? There's some subtle evidence maybe of some AV dissociation in there. What else? There's axis in no man's land. All right. And also you've got a very deep S wave in V6. So there's several things that are saying this is definitely VTAC. This patient got taken to the EP lab, and this was proven to also be ventricular tachycardia, even though he's only 29, even though he's got a stable blood pressure. So what is the best immediate treatment? And answer is a procainamide. Fantastic drug for stable ventricular tachycardia. Adenosine will not work. Magnesium, maybe there's some data saying magnesium is helpful, but procainamide definitely has the best data. And beta blockers, not so good for somebody in VTAC. Okay, number 19. 64-year-old woman presents after syncope. She is unstable. She's got an unstable Brady dysrhythmia. And once again, what's the rhythm and what's the treatment? So we're going to take a look down there. And once again, I think you appreciate the fact that there are P waves that are not being conducted. So this is some type of AV block. Is this Mobitz 1? Is this Mobitz 2? Or is this third degree? How do you tell the difference? Well, your answer lies in the PR segment. So let's get those. First of all, let's map these out. There's a P wave which maps out to that, which then maps out to that, and that, and that, and that, and moving over to that, and that. Okay, so the P waves are occurring regularly. Now, how do you tell whether this is Mobitz 1, Mobitz 2, or third degree? You need to look at the PR intervals. All right, so let's take a look. Well, there is a P wave that's not conducted, so there's no PR interval there. That PR, and compare it to that PR, they're the same. And then you get a P wave that's not conducted, right? So based on this section right there, the PRs are staying constant. That means that this is Mobitz 2. The other clue here that this might be Mobitz 2 is that you've got a right bundle pattern, and Mobitz 2s almost always exist with bundle branch block patterns Mobis 1s can, I guess, also, but more common with the Mobis 2. And the key thing, once again, the PRs are staying constant. So this is a Mobis 2, and with the Mobis 2, you just go right to a pacemaker, all right? You're not going to probably mess around with atropine. Just Mobis 2 goes right to an atrial electrical pacemaker. And then number 20, a lot of people thought 20 was the easiest case, and it turned out to be the toughest case. The most common miss on the test, all right? And this was sent by Sean Fox a handful of months ago. A 63-year-old man presents with chest pain and shortness of breath. He's hemodynamically stable. Here's the EKG. What's the most appropriate initial thing you're going to do? And everybody thought this was a piece of cake because there's ST elevation in lead 1 and an AVL. And so everyone said, well, this is clearly a lateral STEMI. Activate the cath lab. Sure, it's 1 o'clock in the morning. Call the entire cardiology team in, or give the patient thrombolytics right now, depending on what you normally do for a STEMI. Well, hold on for a second, all right? This is a little bit of a trick, but again, this, just like all the rest, is a real case. This is real emergency medicine that you've got to pick this up. There's something a bit unusual about this 12 lead. You know, it's kind of strange for the QRS to be pointing down in 1 and pointing down in AVL and pointing up in AVR. You know, that's a very, very strange axis. And another thing, which again, I'll say it again, we've talked about before, is that in general, the QRS complex in V6 should never be in the same direction as AVR. There's literature backing that up as well. They should always be opposite. So if V6 is going up, AVR should be going down, or vice versa. If V6 and AVR are going in the same direction, your first thought has to be improper lead placement. And that would also be verified. That would also explain why AVLs kind of looking and 1 are looking like they're heading in the wrong direction. So what happened, the key answer here is to repeat the 12-lead EKG. You don't want to give thrombolytics or activate your entire cath lab or stick a needle in, for God's sake. You don't want to do that. Just repeat the 12-lead, double-check the lead placement, and repeat the 12-lead. And that's exactly what they did, and they found that the leads were improperly placed. So here's the EKG when the leads were properly placed, all right? So there's no STEMI here. AVL is back to the way we expected. There's clearly ST segment depression and acute coronary syndrome going on, but does this patient warrant thrombolytics? No. And you notice again, V6 is heading upright and AVR is heading in the opposite direction. So this was a case of improper lead placement, and your answer there is simply to repeat the EKG and certainly not to give this patient thrombolytics. All right. So that is the 2014 University of Maryland Emergency Medicine Residency EKG competition, and I'm tabulating up the scores, and I have not yet announced the winner from our residency, but there's a few people that scored extremely high so far. I hope you scored extremely high as well. If not, keep practicing EKGs. Keep watching the videos. Consider checking out that eMed Home online curriculum, which again is the basis for what we teach our residents and the basis for this EKG competition. Keep practicing. Practice with your colleagues. Get better and better and better. Remember, we always say EKG is the simplest, most important test in all of emergency medicine. This simple piece of paper with ink can save a life, but only if you get really good at it. And we emergency physicians have to be the best at reading EKGs. And if you're not in emergency medicine, but you're reading EKGs, it doesn't matter what specialty you're in, you've got to be the best at reading EKGs. And the only way that'll happen is by practice, 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 practice. And I hope these videos are helping out. So again, kudos to all of you that took the test and did it fairly without skipping right to the answers. I hope this was helpful. And we'll be back to regular cases of the week next week. Until then, bye for now.